Our first presenter is Dr. HAYWARD. She is a professor at McMaster University. She's also the head of coagulation for the Hamilton Regional Lab Medicine Program and program director of the McMaster Fellowship Programs in Coagulation and Hemostasis. She was the past president of the International Society of Laboratory Hematology, also past president of THESNA and the North American Specialized Coagulation Lab Association, NASCOLA. She has published extensively on diagnostic tests and bleeding disorders, including approaches to diagnosing rare and challenging disorders. She is a physician researcher and has received many gold medal awards, including Canada Research Chair and Heart and Stroke Foundation Career Investigator Awards, the Brenhoen and Biggs McFarland Lecture Awards, and she's extremely passionate about promoting excellence in practice and education. So everyone, please help me to welcome Dr. HAYWARD to the podium.
This podium's a bit daunting. It's an absolute pleasure to be here, and this is a topic that I feel really passionate about, so glad to share ideas and experiences about how we approach the diagnosis of ultra-rare bleeding disorders. I don't have anything relevant to disclose, and I've listed some helpful references here. We recently published a paper on factor 13 deficiency that I'm not going to touch on, but since we published that, in a 6-week period, we've diagnosed more acquired deficiencies than we had in the previous year. So it might be an interesting read for people. So ultra-rare bleeding disorders are a challenge because many of the patients we see in clinic that we think have a bleeding problem that we currently classify as a problem of unknown cause. So are you sure it's an unknown cause and not something rare that you haven't tested for? Rare disorders, patients with those conditions are at high risk for a delayed or a misdiagnosis. They may require special or customized treatment, and if not diagnosed, it can have a big impact on their life decisions, including having children, what kind of work and recreation pursuits they undertake. Tests for rare disorders are often not available locally, and you need strategies, which people often don't talk about when you would test for different things. Guidance does help, and so I hope to provide a bit of that today. But we also have gaps in diagnostic tests, and it's really hard to convince commercial enterprises to take on developing a diagnostic test for something that's rare because it's not economically gratifying for them. So we need to have a lot of advocacy. I had the pleasure of being on a working group on ultra-rare inherited bleeding disorders where we got to share ideas and experiences on how we can improve diagnosis and treatment, understand the biology, come up with new tests, and overcome some regulatory hurdles. Where this is going to go, I don't yet know. I want to make this real. I know there's some people in the room that aren't physicians. They may be patients. There may be people who support people with bleeding disorders. So let's make it real by discussing some people who have ultra-rare disorders. First is a man that I met in his middle life, negative family history, no SIBS, but a very positive personal bleeding history with lifelong experience of delayed onset bleeding with challenges, typically not happening until 4 or 5 days later, severe bleeding with dental extractions, tonsillectomy, chest tube insertions for spontaneous pneumothorax, a bleed in his spleen, other bleeds, many requiring admission to hospital and blood transfusion. Some of his spontaneous bleeds were in his kidney. He ruptured his spleen because of a bleed, retroperitoneal bleeds, some requiring ICU care. And he'd been referred already 5 or 6 times for diagnostic evaluation with no answer given to him. So in 1996, he was given empiric antifibrinolytic therapy and stopped bleeding. and then got referred. And within 24 hours of him setting foot at our center, we diagnosed that he had alpha-2 antiplasmin deficiency. His children were carriers. He was so excited to have a diagnosis and to have a treatment that worked, so he bought a boat and called it My Second Life. So let's talk about another real person that you might say, well, this doesn't sound like anything unusual, but 22-year-old female came into clinic on the same day as her uncle, referred for evaluation of a so-called platelet disorder. She's got a history of somewhat heavy periods, a bit of prolonged nosebleeds in childhood, no major challenges, bled with a urinary tract infection, but the family history was quite positive. This is a picture that her uncle shared to me of his legs. He's had bad bleeding problems all his life, so at age 45, he finally gets a diagnosis. He had a chronically low platelet count, so was presumed to have a platelet disorder and was given the usual platelet disorder treatments of DDAVP or platelets. And his history was always uncontrolled bleeding that starts with a delay. Things look okay that first day, but bad problems happen the second day and can go on for weeks or months. He had many joint or muscle bleeds. That's something not typical of a platelet disorder. And you can see what happened to his lower leg after a sports injury fracture. He developed compartment syndrome and ended up losing most of the muscles in his lower leg, and it affected his upper leg strength as well. When I asked him, is there anything you've had done where you didn't bleed? He said, there was a tooth extraction. I got an Amicar for that one, and I didn't get an Amicar for anything else. So we had their consent to test him for Quebec platelet disorder. They were positive, so was the niece. So we identified additional family members. These persons are actually Anglophone. We don't know what their connection is to the rest of the Quebec platelet disorder pedigree. And this fellow has been so pleased to see how well he responds to therapy, but also a bit shocked and hurt by the fact that he went 45 years without the right treatment. So let's go over some bleeding disorders that are challenging to diagnose. That includes some rare defects causing multiple factor deficiencies, some rare defects that affect anticoagulant or fibrinolytic pathways, and some rare defects affecting an aspect of something that we don't test in the lab, such as platelet procoagulant activity. So how do we approach these problems? With the cases I presented to you, I think the first thing we want to do is really listen to the patient and hear what they're telling us about their problems. This is my own strategy for what to do when we have coagulation test abnormalities or not, and we're trying to sort out, is this a rare disorder that we could be looking at? So if factors are abnormal, it sends us on pathways to think about some rare disorders that we could diagnose. But sometimes we're faced with all the tests being normal and having to think about factor 13 problems, fibrinolytic problems, and some rare problems with thrombomodulin that we'll cover. And there's also some disorders that prolong coag tests that we don't get an easy answer for, so we're going to cover those too. I'm having a little bit of trouble with this pointer. Okay, so what about rare autosomal recessive disorders that affect multiple coagulation factors? What we rely on to diagnose these deficiencies is what's low. So there have been reports of combined factor 5 and 8 deficiency, a vitamin K dependent clotting factor protein deficiency, that's autosomal recessive. And our pediatrician colleagues will see patients at times who have coagulation abnormalities due to a congenital disorder of glycosylation. Combined factor V and VIII deficiency is not nearly as common as people making an error in preparing plasma and sending us an EDTA anticoagulated plasma tube to do a factor V and VIII deficiency. So if we ever see that, my first action is to run the sample down to the chemistry lab and get a potassium to make sure it's a real thing and not a pre-analytical error. So these are rare disorders that can cause a mild to moderate bleeding problem affecting factor V and VIII. Vitamin K dependent clotting factor deficiency is again a rare bleeding disorder caused by a defect in one or the other enzyme involved in vitamin K metabolism. So either in GGCX, which is responsible for post-translational modification of vitamin K-dependent proteins, or in the enzyme VCOR that regenerates reduced vitamin K. So this is typically a child presenting with vitamin K deficiency that persists despite treatment. So these mainly present as bleeding, although there are also anticoagulant proteins that are vitamin K dependent. And so we will typically measure the factors, but somebody could be asking the lab to assess also the levels of protein C and S. And we need to suspect these disorders if the patient isn't responding to treatment. Congenital disorders of glycosylation are not something that I see as an adult hematologist. They have a high mortality early in life. They typically present with combined problems, and there can be an array of coagulation proteins, anticoagulant proteins, von Willebrand factor, and platelets that are affected by the disorder. So you really need to work with the clinical service to decide what's appropriate to measure. Inherited thrombomodulin-associated coagulopathies are really interesting disorders, and you'd have to say, oh, how would I ever come to suspect this, and what would I test? So these are disorders that affect the ability of thrombomodulin to anticoagulate blood through the activated protein C pathway. It also has roles in activating a fibrinolytic inhibitor. And these patients with the autosomal dominant form present with a bleeding problem with negative investigations. It does, however, cause reduced serum prothrombin consumption, so that might be a relatively simple test to think about doing. And a couple of mutations have been described that increase the levels of soluble thrombomodulin in the plasma to cause this disorder. That soluble thrombomodulin in plasma is active as an anticoagulant. The rarer thrombomodulin disorders are recessive, and we think they cause deficiency because they have undetectable soluble thrombomodulin levels. So they run into problems with episodic worsening of a consumptive coagulopathy picture. So what about if you're looking at a patient who's got a prolonged PT and APTT, but all the factors come back normal, including fibrinogen, you exclude a lupus anticoagulant? What on earth could this be? So there are several bleeding disorders that have been described that are autosomal dominant, and they're caused by mutations in coagulation factor V that affect its anticoagulant function. So factor V, many people think of it as an important procoagulant that accelerates thrombin generation through its action as a cofactor for prothrombinase, but it is also a carrier protein for tissue factor pathway inhibitor in our plasma, and so it's got anticoagulant functions involved with the protein C pathway and with TFPI. So this schematic shows you on the extremes in A, coagulation factor V in its full-length form, where there's that loopy B domain that's got a basic region that binds to an acidic region and prevents tissue factor pathway inhibitor from binding to factor V. But on the other end of the slide, in E, is something called factor V short. That's an alternative transcript. It's lacking that loopy B domain, including the basic region that is homologous to a region of tissue factor pathway inhibitor. So if your body makes too much factor V short, your plasma now contains increased tissue factor pathway inhibitor that prolongs your PT and PTT, but everything that the coagulation lab usually measures is normal. So there are 3 different mutations that have been described to cause this. They're all mutations in the part of the factor V gene, exon 13, that encodes the B domain. 2 of those mutations increase the efficiency of producing the normal form of factor V short. And in factor V Amsterdam, it's a unique factor V short transcript. The one that causes the worst bleeding that can include muscle and joint bleeds is factor V Atlanta because it increases TFPI levels more. So when to suspect these disorders? If you have an autosomal dominant bleeding problem with mucocutaneous and challenge-related bleeding, and the lab finds typically a 5 to 13 second prolongation of the PT, 15 to 22 second prolongation of the APTT without factor deficiencies or a lupus anticoagulant, may show full or partial correction in a 1-to-1 mix. And because it's hard to get tests for measuring factor V short or TFPI levels, the easiest way to diagnose these conditions has been to go to molecular testing. I want to move now to talking about fibrinolytic disorders. So these are something that we have to order specific investigations for, and there's 3 main conditions that we know can disturb fibrinolysis due to an inherited defect. 2 are due to mutations that cause a loss of function in an important inhibitor of the fibrinolytic pathway. So either a mutation that reduces PI1 levels, so you've got unopposed plasminogen or increased plasminogen activation that leads to secondary consumption of alpha-2 antiplasmin as part of the phenotype, or alpha-2 antiplasmin deficiency like that gentleman that I presented to you. The other possibility is Quebec platelet disorder, and I'll explain the mechanism about that in a few slides. It's a gain-of-function defect that involves platelets and delivering too much plasminogen activator. So when do we think about testing for these things? I think as soon as you think about testing for factor 13, you should say, well, why am I not testing for fibrinolytic problems at the same time? They tend to present with very similar symptoms, except PI1 deficiency in women causes problems with bleeding during pregnancy and may affect the ability to carry a pregnancy to term. Quebec platelet disorder differs in terms of its dominant inheritance. So for alpha-2 antiplasmin, we order levels for this. You always measure something even if there's no alpha-2 antiplasmin because alpha-2 macroglobulin contributes to the antiplasmin activity in our blood. And we do see acquired deficiencies in consumptive states. I like to test for PI1 and alpha-2 antiplasmin deficiency at the same time. PI1, probably the easiest screening test for your lab to do is something called a euglobulin lysis time, which is abnormally short in PI1 deficiency because the antigen and activity assays, some of those activity assays can't be used for diagnosis, are very rarely offered by diagnostic labs. And if you have molecular testing, that's also important. So for Quebec platelet disorder, there's no good screening test. You can, like the gentleman I presented, have a mildly low platelet count. There's absent secondary aggregation with epinephrine, which is pathognomonic of the disorder, but not specific. And it, interestingly, is part of the phenotype that reverses on prolonged tranexamic acid therapy, so directly related to the fibrinolytic problem. And so these individuals have a duplication mutation that creates a unique breakpoint, and it's very simple to go straight to genetic testing and forego doing other investigations, which are not as specific. It causes bleeding for strange reasons. So there's a duplication mutation on chromosome 10 that gives an extra copy of the gene for urokinase plasminogen activator, but the rearrangement puts a switch, an enhancer element that normally turns on the downstream gene in megakaryocytes that encodes vinculin. And so now plow behaves like vinculin in megakaryocytes and gets turned on and puts more than 100-fold the normal amount of UPA into platelets, which then when you go to stop bleeding and your platelets stick, release all this urokinase plasminogen activator that causes bleeding. So final message is people with ultra-rare disorders have important histories to share. We need to listen and learn from them. We need strategies for when and how to test for the rare. If you don't look, you won't find. Some don't have a known cause or good treatment, and we need those patients to inspire us to do research and find solutions, and we need to advocate for better understanding and testing for these disorders and better treatments. Thank you.
I think we can open the floor up for a few questions. Does anyone have any questions for Dr. Hayward? That was a wonderful presentation. Thank you. I had one question, actually. In terms of the fibrinolytic disorders, is there any role for things like ROTEM in detecting that initial fibrinolytic problem and giving you a clue that maybe we should be looking down that way?
So they're not validated to help detect inherited fibrinolytic defects. The TAG does not pick up the fibrinolytic problem in Quebec platelet disorder. Right. It requires more UPA than is in their blood. So we're really looking at ordering a euglobin clot lysis time, ordering alpha-2 antiplasmin levels as a good first way to screen for these conditions, and in the case of Quebec platelet disorder, going straight to molecular.
Going straight to molecular, okay. And any correlation with D-dimer levels or fibrin degradation products, does that come up at all?
If somebody's had a bleed and a big hematoma, their D-dimer levels are going to be up acutely, and we don't usually go testing them. I know in Quebec platelet disorder, they're normal, so the fibrinolytic problem is really localized to the clot. You can get high D-dimer levels in the autosomal recessive thrombomodulin-associated coagulopathy. I'm not sure what happened. I thought I had a slide in my slide deck about two patients that I recently saw who had massive muscle hematomas that I've pretty much exhausted everything, and recently did a serum prothrombin consumption test, and they're both really abnormal. So I think we may have two cases with a autosomal dominant thrombomodulin-associated coagulopathy at our center. And I don't know, is there anyone here except me who's ever ordered a serum prothrombin? It's a simple test for your lab to do, so if you're interested in setting it up, contact me and we can share what we do. So it's basically making serum, incubating whole blood without an anticoagulant, and then measuring factor 2 at the end of the test.
I think we've got one question here from Dr. Steele.
Hi, Max Steele from Calgary. Thank you very much. I think I find, probably like lots, but very challenging to think of these more rare disorders. And you mentioned a lot of molecular testing. And I think one challenge with molecular testing is a lot of these panels are quite large, so we want to avoid picking up things that maybe aren't directly relevant to the patient's case. So do you know of a very sort of targeted panel, or perhaps you offer that in McMaster, I'm not sure, that would just sort of focus really on these, or would we just have to work with a commercial lab to develop a, very targeted sort of ultra-rare bleeding rather than getting, for example, like, familial platelet disorder or RUNX1 and stuff that I don't really want necessarily, a 5-year-old to learn about. It may not be relevant.
It's a big problem. What I usually do is refer the patient to our genetic service and talk about what we're suspecting. So then sometimes they'll just do targeted investigations. If those come back negative, then you kind of wonder, oh, should I have looked a little further? And we probably have a problem in that some may have mutations that aren't described or might not necessarily be identified as pathogenic, and you're really not getting the full information that you could get out of the test. So our genetic service says they can get the Ontario government to fund the test if there's a 5% or greater chance of finding a mutation. So that for many of our patients with rare bleeding disorders is there. And so, but it's usually a matter of months to get an answer. Thank you.
Thank you so much.